Okay, we're going to continue talking about the esophagus, looking at the diaphragm and how the esophagus is separated by the diaphragm and meets the stomach. And then we will look at the innervation of the esophagus and then talk about a few clinical correlates. And in the previous video we talked about the esophagogastric junction down here, which is also known as the Z-line, and this is the abrupt transition from the esophagus to the gastric mucosa. So remember that it's called the Z-line clinically. And so let's take a look at some of the structures here. So imagine that you had swallowed some barium, contrast medium, in the esophagus, and here there would be a constriction, the thoracic constriction of the bronchoaortic area, in the bronchoaortic area. Here is the transverse process of the thoracic vertebra, and then moving down you can see an intervertebral disc, and skipping down to the bottom we're going to meet the diaphragm, and this is where there would be a diaphragmatic constriction, and it would continue on as the abdominal esophagus until it meets the stomach. So what's important here to pay attention to is the positioning, and through radiological studies we know that food or liquid may be stopped here momentarily, and that the sphincter mechanism is normally efficient in preventing reflux of gastric contents into the esophagus, but it doesn't always work. So let's think about the innervation next. Okay, so let's talk very basically about the innervation of the esophagus as it comes down to meet the stomach at the Z-line. Anyway, let's talk a little bit about the anatomy, and let's look at the sympathetic trunks on either side. So, for example, you can see the right thoracic sympathetic trunk, and coming off this right thoracic sympathetic trunk is the thoracic splenic nerve, and you can see that the splenic nerve is coming off and coming down here. And next on the other side we can notice the right vagus nerve, which becomes the posterior vagal trunk. You can see that right here. Oh, sorry, up here. And then if you look down a little further, you can see the left vagus nerve, which becomes the anterior vagal trunk. So I think we can focus on the important things here, and that is this area here, which is the periarterial plexus, which is around the left gastric artery and the left inferior phrenic artery. I'm not sure if I'm hitting the right area here, but it's important to remember this periarterial plexus, which is around the left gastric artery and the left inferior phrenic artery. So now we can move on to talk a little bit about the clinical correlates. So first off, we can look at this picture down here, and commonly we see esophageal damage from reflux, from acid reflux, one of the big problems, as the acidic content would flow back into the esophagus. And at this time it would be good to discuss Barrett's esophagus. And Barrett's esophagus is when the normal stratified squamous epithelium lining the esophagus is replaced by simple columnar epithelium with goblet cells. and this is when Barrett's esophagus is diagnosed. And one of the dangers here is that Barrett's esophagus has a strong association with esophageal adenocarcinoma, which is a particularly lethal cancer. So you should be aware of patients who are complaining of chronic acid reflux. So now let's turn to look at a hiatal hernia. And you can notice here, perhaps it's difficult to see, that the fundus is actually popping through. The fundus of the stomach is actually popping through here, and it's going through the diaphragm, and so this is also going to increase the risk of acid reflux. So these are a couple of clinical correlates.